Welcome to Health Matters, where we explore key topics from a primary care perspective. I'm your host, Dr. Sheylan Spencer. Here at Vandalia Health, we are passionate about bridging the gap between primary care and specialty medicine, ensuring that complex medical topics are accessible and understandable for healthcare providers and patients alike. In each episode, we'll dive deep into the latest advancements, best practices, and critical insights to help improve patient care. Thank you for joining me on this journey toward better health. Today, I'm pleased to announce that we have Dr. Adina Bowe joining us. Dr. Bowe went to medical school at the University of West Indies, Kingston, Jamaica. She completed med psych residency at WVU Charleston Division, and later went on to complete addiction medicine fellowship at Yale University School of Medicine. Dr. Bowe's special interests reside in treating medically complex, dually diagnosed individuals with addiction disorders in rural communities. She is an advocate for the integrated care model of health delivery. Dr. Bowe is an active member of the American Academy of Addiction Psychiatry, the American Medical Association, and the American Psychiatric Association, as she is passionate about integrated care and substance use disorders treatment. She has co-led workshops at the AAAP and APA that are geared towards training psychiatrists in how to engage family physicians and internists in addiction treatment. Dr. Bowe is an ASAM and PCSS MAT trainer for medical facilities in rural West Virginia. Dr. Bowe, thank you so much for being here today. Your background is extremely impressive, and I think our listeners are really going to benefit from the perspective you bring, especially when it comes to treating patients with substance use disorder and mental health and medically complex patients.
Thank you. I'm really happy to be here. These are such important conversations, and I'm excited to be a part of it.
You know, as a family medicine resident, I can't count how many times I've seen patients whose mental health and substance use disorders are either overlooked or just kind of siloed from the rest of their care. So I'm really looking forward to talking about what integrated care actually looks like and how we as primary care providers can show up for these patients more effectively.
Absolutely. This disconnect between mental and physical health is something we see all the time. Integrated care is not just a buzzword, it's truly necessary if we want to get better outcomes, especially for our vulnerable populations.
You know, I know a lot of our listeners, whether they're trainees or practicing clinicians or just interested in health systems, probably run into some of these challenges. So let's get into it. I've got a case here that I really think will get us into the heart of the discussion. Our first patient is Mr. Marcus. He is a 22-year-old male brought to the emergency department by his older sister. She's concerned that over the past 2 weeks, he's become increasingly withdrawn. He's actually been stopping going to class and rarely sleeps. Over the weekend, he's been claiming that drones were following him and that his professors were part of a conspiracy to fail him. He's visibly anxious, he avoids eye contact, and occasionally mumbles to himself during the visit. He has no documented psychiatric history, no known substance use, and no medical comorbidities. He's not on any medications. His sisters, they're also present, and they say there is a family history of mental illness, but they're not really sure what that entails. His blood pressure is 130/72, heart rate's 84, the rest of his vitals look okay. On exam, he's guarded but cooperative. He denies any suicidal or homicidal ideation, but does say, "I know they're watching me. I don't want to talk about that here." You know, Dr. Bowe, when you first hear about Marcus's story, what's kind of running through your mind?
What's running through my mind, I'm thinking about this young man who comes to us with his sister. First of all, I'm so happy that he has engaged family members who seem to know about him and care about his health. But he's brought in with very concerning symptoms that's suggestive of psychosis, as if he's having a mental or emotional breakdown. So I'm wondering what's going on here, how long has it been happening, how strong is that family history, and how we can help him. He said he was pretty scared and didn't want to talk. So I'm thinking, well, how can I engage him? How can I make him feel safe?
Dr. Bowe, what are some big red flags that or key details that really just jump out to you?
Well, some of them are, first of all, his age. We know when it comes to psychotic disorders, especially in men, they tend to present in that age group between 18 and 35. So I'm wondering, is he now starting to present with the first episode of psychosis? Other things that jump out to me is that there's this family history of some vague disorder, we're not sure, we kind of have to get into that. But also look at the dysfunction in his life. He's had to stop school. He can't do his classes. He's withdrawn. He's locked into himself. So I'm kind of wondering what's going on here. And those are big signs and flags that things are not right and things have changed.
That's so good. 2 weeks of these changes, how does that timeline shape the way you're thinking about this?
So when I think about 2 weeks, I'm thinking, is this something that's more acute? Did something happen in his life? Did he have like a traumatic event? Did he go through a breakup? And I'm also thinking, well, 2 weeks kind of gives us some information if he has some mood disorders along with it, like depression. You have to have symptoms for a long enough time to have a psychiatric diagnosis. So I'm kind of thinking, is this a mood disorder, or is it more of a primary psychotic disorder? Or even, is he just starting to use substances? Did he dabble at some party? Did something happen?
I think the question vignette said that he's withdrawn, not sleeping, and now paranoid. So you mentioned mood issues and a primary psychotic process. How do you kind of sort through those things?
So when I look at those things, I first of all try to get a timeline and baseline information on what his personality was like before. Family members are important here. You just get that information. Then I think about symptoms. So when I know when I'm looking at a primary mood disorder, such as depression with psychosis, I'm looking at like maybe 2 weeks of severe depressive symptoms, and then you start to have some psychosis over time. If I'm thinking about a first episode psychotic disorder, those symptoms can develop pretty rapidly.
So you're in the emergency department. What are some things that you want to hear about in terms of like labs or tests that are must-haves before you could really call this psychiatric?
Okay, so it's very important when we meet patients for the first time to figure out, is this a medical condition or is this a psychiatric condition? And so we go ahead and look at things we call the basic metabolic profile. We look at the urine drug screen. We go ahead and look at their kidney function. We would do other labs in terms of if there's indications like ammonia, if there's a change. We look for infections, because sometimes something called delirium, where you can be very confused, acute infections can cause that. So there's a variety of tests. And also, of course, if he's hearing voices, seeing things, a CT scan brain.
You mentioned substances and things like tox screen. What substances would we be suspicious for in someone presenting like Mr. Marcus?
So big in our population, things that would make me think about psychosis and paranoia are our stimulants. So that's like methamphetamine, cocaine, but also our medications like THC, because we have Delta 8, Delta 9, and Delta 10. And depending on what's in them, they can cause psychosis over time or even in the acute setting. Also, what's coming up in a lot of our college-age kids are like LSD and mushrooms. Depending on how you do them, that can cause psychosis. Also, I would look at him and see, are you a bodybuilder? Are you someone who's recently been on steroids and now stop? Because sometimes using steroids and then stopping can also cause psychosis, or even high doses of steroids. So it's a variety of things.
He mentioned the drones and conspiracy ideas. How do you kind of tease apart true psychosis versus just odd or strong-held beliefs?
That's a very good question. So when we think about people who are maybe odd or eccentric, we think about a pervasive pattern. All their life, they're this way. They wouldn't have a presentation that 2 weeks there's a change. They would say, no, I believe in UFOs. I've been seeing them all my life. They don't really disrupt their thinking or their functioning. It's just that they have odd beliefs. Whereas something as a psychiatric condition, you can see the abrupt change in behavior or thoughts.
The clinical vignette mentions that he's mumbling to himself. Can you kind of just walk us through your approach to kind of probe out whether these are hallucinations or not?
Okay, so first of all, when anyone is mumbling to themselves, I kind of ask them, I'm say, hey, you seem to be having a conversation. Is there anyone around? Can I see that person? Not see that person? I'm also careful to ask, is it okay if I ask you about the mumbling? Because sometimes when people are hearing voices that they're engaged in, the voices actually say, don't talk to anyone else. So pretty much I kind of ask the patient, you're talking. Are you talking to anyone? And just go by what they say.
Thanks for kind of walking us through that. Do you have any other advice on how to really tease out insight whenever you're talking to a patient? Just to try to avoid shutting them down more.
Yeah, a lot of times patients feel very embarrassed by their symptoms, particularly if they're aware of them. So sometimes I like to normalize it. I say, there are many people who hear voices or see things that are not there. Have you ever encountered that? Do you have friends or family members like that? Then I also say, it doesn't make you crazy, because a lot of people need to hear that in order to go ahead, because we don't like to call our patients with psychotic disorders crazy, right? They're having problems with reality and problems with cognition. And then I kind of ask them more questions about it. I'd be like, is it male voice or is it female voice? Is it in your head or outside your head? And sometimes they ask me, what do you mean by if it's outside my head? And I tell them, take your hands and cover up your ears and tell me if you can still hear those voices. Okay, it's just to get them comfortable talking about it. Just remove the shame of it.
So we talked about whether this is medical versus psychiatric. We talked about like the workup in terms of the BMP, maybe a talk screen if it's necessary, and then of course if there's any neurological symptoms, like talking about getting the scan. Can you kind of just walk us through like your differential in terms of like if this were psychiatric, what you would think about?
Yeah, so for sure. So when I think about someone who comes to me the first time, kind of withdrawn, mumbling to himself, being paranoid or psychotic, I think about a brief psychotic disorder versus a schizophreniform disorder versus a schizoaffective disorder or versus substance-induced mood disorder or even schizophrenia. And a lot of times the diagnosis is longitudinal. I usually tell my residents there's no way you can absolutely know what's going on with a patient the first time you meet him. So just kind of sit and have a list in your mind. So people who I think more about brief psychotic disorder, they can happen at any age, right? You have an event, like maybe you lost your job, you found out something difficult, and then you have a snap and where you lose touch with reality. Those have a pretty good prognosis. Whereas someone maybe with schizophreniform, they had these symptoms going on for maybe about 1 to 6 months, not quite reaching 6 months. But you hear voices, you see things, you're withdrawn. Once you hit the 6-month mark, we say you probably have schizophrenia or schizoaffective disorder.
That's so it's kind of like timeline driven is what I'm hearing.
Very much.
What does disposition look like for this patient? When would you think about like admission versus like a close outpatient psychiatric?
Follow-up?
I'm going to re-record that. So what does disposition look like for this patient versus admission versus like close follow-up?
So disposition definitely depends on presentation as well as insight as well as severity of symptoms. So if I have someone who comes to me and they're hearing voices, they're kind of withdrawn, they're paranoid, but there's nothing telling them to kill themselves, there's no command hallucinations telling them to go burn down a house, go cut someone, go hurt someone, and if they're able to not obey commands they're given, I can offer them an outpatient treatment plan. However, someone has lost touch with reality, can't tell what's real and what's not real. The voices are degrading, they feel guilty, they feel ashamed, they're scared. I offer them inpatient admission. And depending on what the patient wants, we decide to start medicine then or not. If they're in their right mind, they can make that decision themselves. If they want to start a med, we do it. If they don't, we don't. We just say follow up as an outpatient. But if they're not quite in their right mind or have capacity, like how the medical term, we have their surrogate decision maker make that decision for them.
You mentioned medication. Whenever you're looking for medication, can you kind of just walk us through how you decide which agent you're going to use?
Oh, yeah. So usually when it comes to medications for all psychiatric disorders, it depends on what's available, what's covered, what patient's preference, and also their comorbidities. So, for example, if this person comes in, he's hearing voices, seeing things, we call it psychosis, we want to give an antipsychotic. Well, we have a whole list, and it all depends on the preparation, whether you can swallow it, get an injection, or get a long-acting injection, or whether you have kidney issues or you have liver issues. So, for example, if you had kidney problems, I would stay away from, we call the Dones, like Risperdal. If you have liver issues, I stay away from quetiapine. We stay away from olanzapine. So pretty much it's based on availability, patient's preference, side effect profile, and family's response also. If they have another family member who's on the medication responded well.
So that was just a beautiful way to really walk us through your thought process in terms of choosing agents. What are some early psychosocial support? I'm going to re-record that. That was a beautiful way, just kind of walking us through the pharmacology about which agents you're going to pick depending on whether there's liver impairment versus kidney impairment. I really appreciate that. When we're thinking about psychosocial support, what are you noticing that's making the biggest difference for your patients?
Okay, so when I think of in terms of psychosocial support, I think about family support. I think about education level. I think about home environment, social environment. I think about extended family support, social circles such as, is there a community around you can be engaged with? Do you have a religious affiliation? Are there certain religious groups you're involved with? So those types of things. So what we find is very important with patients who might be experiencing psychosis is their family support. Family should know what's going on, know what to anticipate, know how to get help, but also connectivity. Are they able to get their appointments? Do they have transportation? Do they have the financial means to keep up with their health and to manage their health? Then what about that wider community around? Are there groups they can interact with to increase their social skills? Do they have the spiritual support that they need or may not need? Are there any peer groups around?
When thinking about patients, Dr. Bowe, with the first episode of psychosis, what's one thing that you want listeners to take away from Mr. Marcus's story?
I want them to know that they're not alone. Many people experience it, and help is there, and help is incredibly effective. And I just want to give a shout out for Prestera. This is our community mental health program. They have this awesome program for first episode psychosis, especially for young people. They would evaluate you. They try to get resources to your home. They integrate social skills, and they try to get you into an education programs. So there's so much help. And they also work along with us because we have patients who we see both in our department, CAMC, but if they have extensive needs, we often refer to Prestera for that wraparound service as well.
What amazing service. I didn't know that existed. Thank you, Kana, for sharing that. It's definitely something that I think is beneficial for the community.
Vandalia Health CAMC is proud to be an academic medical center, which means we're training and preparing future doctors, nurses, and other health professionals to deliver the highest quality care. Through innovative research, advanced learning experiences, and more than 20 residency and fellowship programs, medical professionals are elevating their academic journey at CAMC to bring you the best care. Stay connected with Vandalia Health for all the latest updates by liking us on Facebook and following us on Instagram and X.
So while Mr. Marcus showed us what a first episode of psychosis might look like, Mike's story is one that reflects really another crisis we're facing today, the opiate epidemic. Let's take a closer look at his case. So Mike L., he's a 34-year-old male. He's presenting to your clinic for routine follow-up. He has a history of anxiety and chronic low back pain because of a workplace injury around 5 years ago. He was prescribed oxycodone at that time, and he's been intermittently using opioids since. Over the past year, Mike has lost his job. He's experienced some relationship strain with his partner and has become evicted from his apartment. He admits to using heroin and fentanyl a few times a week, mostly by snorting, but he does admit that recently he started injecting, occasionally. He expressed ambivalence. I want to stop, but I'm not sure I can. He reports anxiety, fatigue, poor sleep, and daily cravings. He does say that he's had one episode of overdose in the past 6 months. Thankfully, it was reversed with naloxone, administered by a friend. Currently not in treatment and is a little bit distrustful of rehab programs. He's heard of Suboxone, and he's kind of curious about it. At this moment, he's denying any suicidal ideations, he's alert, he's cooperative, and it appears that he's appropriately dressed. Vitals are stable. Urine drug screen is positive for opioids, fentanyl, and benzodiazepines. Liver enzymes are mildly elevated. HIV and hepatitis C are pending. Dr. Bowe, can we just kind of talk about Mike? He's 34. He's dealing with both some anxiety and chronic pain. And he says he's been using heroin and fentanyl pretty regularly. Where do you even begin when patients are, kind of in that in-between space of wanting help but not fully ready to commit?
Well, first of all, my approach to him would be just to encourage him and to thank him for even coming in and talking to us about it. It is awesome when a patient discloses how much they're struggling with a substance, because there's so much shame surrounding that and so much helplessness. And so usually with my patients, I just let them know I'm going to partner with them in it. I'm not here to force them to do anything. I just want to know where they're at and what they would like for me to do. I would say most of my patients, when I first see them, they have a lot of ambivalence. They're on the substance, it's hard to get away from it, not quite sure if they're ready. And so I just meet them right there. I'm say, hey, you say you might want to stop. Well, what's making you think about stop? What's getting you there? Why do you want? Why is that important to you? Because I always feel it's important to partner with your patient to figure out what's important to them and what's motivating them to get to stop. And from there, we can build.
So I'm hearing some good education just about like forming a partnership and things like that. He mentioned he's curious about Suboxone. For people who don't know, what actually is Suboxone, and how does it help someone like Mike?
So Suboxone is actually a trade name for a medication. It's called buprenorphine naloxone, and it is awesome. It is one of the medications we use for people with opioid use disorder. And what I like about it is that it's easy to use. You can give a week's supply at a time for people who are first starting out. It brings down cravings. It takes out withdrawal. And man, it really helps get patients their life back. So medications are super important, but so also is the support, right? The therapist support around them. We have a whole team here at CAMC who really try to get around the patient, get them initiated on Suboxone, both in the inpatient and outpatient unit. Suboxone, we say, is a partial agonist, which means it works in the same area of the brain as heroin and fentanyl, but it acts a little different. So it doesn't get you high, not at all. But what it does do is bring you to a point where you can think rationally, you can not crave the substance, and just basically get you back to functioning.
I think it's important to call out that Mike isn't new to opiates. He started on oxycodone after an injury. How often do you see stories like this? People starting out with prescribed medication, and then he's ending up here.
I would say probably 80% of my patients who are over 30 or 40 have been started off in prescription opioid medications. In the younger age group, I don't see it as much. They actually start off on maybe street buprenorphine or fentanyl heroin. But it's devastating because so many people were exposed to opioids, and appropriately so, but had difficulty getting off of it, right? So you really feel for patients who come to you with this problem, knowing that, hey, as clinicians, we kind of got you there.
One thing that really stood out to me was the overdose. He said he survived because a friend had naloxone. Do you think we're doing enough to make sure naloxone is available and that people know how to use it?
I think we have definitely doing more than we did in the past, but we can always improve. So in different parts, every pharmacy has naloxone that's available for patients. You can get it many pharmacies even without a prescription. But I always feel that every patient and every family member, if you have someone in your home who you know is using substances or prescribed prescription medicine, man, you should have that Narcan kit there. Narcan is so easy to administer. You just need to get it, and if you suspect an overdose, you just go ahead and just put it in their nose. If you're in a hospital system, we have a different way of getting it, but we definitely need a lot more naloxone education, for sure, and availability.
We talked about earlier, you mentioned Suboxone, how it's a wonder drug. He's also complaining of some emotional symptoms like anxiety, maybe some poor sleep and daily cravings. How much of that would you consider it being withdrawal versus how much of this could be like a mental health picture?
That's a very good question. We know that maybe 40 to 60, 70% of patients with opioid use disorder also have comorbid psychiatric illness, and that could be depression or anxiety, schizophrenia, or bipolar disease. So I would say it's hard to tell right away. Almost everyone who is in withdrawal from opioids will experience depression and anxiety. So we kind of wait. We kind of wait till they get through that, and then we keep evaluating them. And then about 4 to 6 weeks later, we do a reevaluation of those symptoms. If they're still there, we call it a primary mood disorder or primary psychotic disorder, and we treat. Because if you don't treat that, it's not likely they will do as well in recovery.
Dr. Bowe, that's a beautiful piece. Last thing, I promise, last thing. What would a realistic, compassionate care plan look like for someone like Mike?
Okay.
No, not a perfect one, but one that actually meets him where he is.
So we always say when it comes to patients in recovery, we have to use an individualized plan for them. Not every patient will respond the same way. So a compassionate approach would first of all to be to ask him, what do you want? What do you think is necessary? How can we be helpful? We would include medications. We will include therapy. We will include family therapy, family support. We will include vocational training if needed. Also case management, which means if you're suffering from housing insecurity or food insecurity, connect you to the right sources. For some people, and when they're in their use, they have strong family support, they're rich, they don't need as much help. Other people, they're financially devastated. And a good plan would be to encompass all of that. And of course, you have to adhere to their medical issues because there are many medical complications from substance use disorders, as well as their psychiatric issues. You have to use the integrated care model managing patients with substance use disorders and all those with mental illness.
What a beautiful piece, Dr. Bowe. You walked us really through a challenging case. You mentioned earlier, substance use disorders are such a critical part of psychiatry, really family medicine as well. This case, I feel like it really highlights both the struggles and opportunities for us as physicians for intervention. If you don't mind, we'll just shift gears really to our last case. This kind of explores really a different area of mental health in general. We have Miss Carter. She's an 82-year-old retired school teacher. She's actually in the hospital setting. She's diagnosed with community-acquired pneumonia. Really her past medical history, she's got a little bit of hypertension, type 2 diabetes, some osteoarthritis, and some mild cognitive impairment that's listed. She lives alone, but she does have supportive care with her daughter who checks in daily. She's actually on hospital day 3, and the nursing staff notes that Miss Carter has become a little bit more confused and agitated. The nurse says she actually tried to get out of bed this morning without assistance. She also did that pretty much throughout the entire night. She's been pulling at her IV lines. During her morning rounds, she's disoriented to time and place, intermittently moaning, and really just trying to remove her oxygen. I think maybe the nurse had reported earlier that she accused her of stealing her purse. Vitals are stable. Labs show mild hyponatremia at 130, and her blood glucose was 65 overnight. Chest x-ray shows improvement, actually. She's afebrile. Current medications include cefepime, azithromycin. She's on a little bit of sliding scale insulin and oxycodone PRN for pain. I think the overnight resident might have given her some diphenhydramine last night for a little bit of itching. Dr. Bowe, you have a story like this. It's an older patient who's seems like is experiencing a little bit of a sudden change in mentation. What's the first thing that comes to your mind?
Well, a couple things come to mind. I guess one of the first things is just, first of all, normalizing it for the family and for the nurse. This looks like your mom, your patient is going through delirium. And delirium is sort of like when you have a sudden change in your mental status, and it's because you're sick. It's because you're getting different medications, your body is not well, you're in a different environment, but it can be frightening to see. It can be sometimes unsafe for staff to experience, but the patient needs a lot of reassurance and help.
Dr. Bowe, that's you mentioned delirium. She also has like a history of mild cognitive impairment. How do you kind of differentiate those two when you're seeing that in a patient's history?
Okay, so the differentiation sometimes can be kind of complex because you can have both occurring at the same time, but usually it goes by family report or patient report. If the family tells you, man, they were fine at their baseline and then this, with that shift, with that inattentiveness, with that disorientation, is more likely delirium. And what makes delirium more likely to happen for some patients are older age. It is a history of baseline mild cognitive impairment. So it's at times, though, it can be tricky because you can have chronic delirium where this process has been going on for 1 to 3 months and not just 1 or 2 days.
For Miss Carter, what are some things that kind of pushes you to, I'm going to re-record that, Jason. Don't put this in. For Miss Carter, what were some big triggers that you think kind of pushed her into this state?
So some of the big triggers that pushed her in, likely the new onset of pneumonia, that can cause it. Also, she has a little bit of a low sodium. Her sodium is 130. Usually we see big changes more at 125, but if she fell from like 137 to 130, that can definitely cause it. Also, she's on PRN as needed pain medications, and when our patients are sick, even their home dose of oxycodone can kind of build up in the system in terms of metabolites and make them not function as well. She also was noted to have a slightly low sugar. Her glucose was 65. And for our older patients, we like to keep it above 80. All right. She's in a new environment. She's not at home. And as you know, in the hospital, you never sleep, right? Because the nurses come in and check on you every hour. So there's all kinds of things that can cause it. We also know she's on a medicine, Benadryl, the dihydramine, the anticholinergic medicine, can make our patients very confused. Good for sleep when you're younger, not so good for the elderly person or the older person.
What a great job. You really kind of just summed up Miss Carter. We hear about an infectious cause, maybe the pneumonia, some metabolic in terms of her hyponatremia and hypoglycemia. And then you talked about medications too, like diphenhydramine and the PRN oxycodone. In regards to like medications, what are some like big red flags? You'd mentioned anticholinergics. What are things that you're seeing in the hospital in terms of like a med list that kind of jump out to you?
So things that really stand out to us are people we call on multiple CNS depressant medications. And that just means things that can affect the way you think and the way you reason. So those medications can be things like benzodiazepines, barbiturates. I mean, many people are on this medicine called Neurontin for peripheral neuropathy. We also see it in the anticholinergics. We can even see it in our medicines, like the high-dose tricyclic antidepressants. We see it a lot inside our pain medications, in particular narcotics, as well as in muscle relaxants. There are so many medications we give our patients that can really, really affect their cognition, especially when they're sick.
So that's actually something I'm going to take into practice whenever I'm prescribing medications, thinking about the patient's age, thinking about things like the Beers criteria. Just stepping back, really, we know delirium happens pretty frequently in the hospital. Sometimes it's missed. What are some things that we can do as physicians to catch it early or even prevent it from happening in the first place?
So in order to catch it early, we always like to say, kind of risk stratify your patient. Who are our patients are more likely going to have problems with cognition? And then we kind of keep an eye on them. So the people who are more likely to have issues are maybe people who are very ill, our ICU patients, people who are older age, people who are on multiple medications, people who are experiencing liver failure, renal failure, heart failure. We look for people who've had strokes and seizures. Those type of people are more likely to have delirium. Also, for sure, are persons who have seizure disorders, are people who have mild cognitive changes, already have dementia. They're more likely to develop delirium. Of course, people who are going to be exposed to anesthetic agents or changes in their pain medications are more likely to experience delirium. There are lots of things we can do to help prevent it or at least minimize it. And CMC nursing staff is fantastic at implementing those, such as minimizing IV lines, open those shades when it's light outside. If you can, get them in a good sleep-wake cycle. Orient your patients every day. Minimize catheters. Bring blankets in from home. Have some music going in the room. Encourage family support at the bed. Avoid sedating medications. Avoid anticholinergics. So that's one of the things I really noticed here. The staff is awesome about implementing that.
Thanks for sharing that, Dr. Bowe. These are things that you hear about. We call them delirium precautions, but you kind of just walked us through those. Some non-pharmacological things that we can do. When is it ever right to jump to medications?
Okay, so when we think about delirium, we put it in three different categories. We say you have hypoactive, which means you're just kind of low in there. People think you're depressed, but you're actually delirious. Then you have mixed, where you can fluctuate between being excitable, kind of picking at the air, violent, and then going into the sleep. Then you have hyperactive delirium, where you're just pulling at lines, you're hitting people, you're cussing, you're having a really difficult time. So people who are disruptive to nursing staff and harmful to themselves in terms of pulling out lines, they probably benefit from medications, because what those medications do is just help them sleep, help them rest. There's actually no FDA approved medication for delirium. And what's important to know is that when you start the medications, they take about 3 to 5 days to work. They're not going to work right away. So patients who are hyperactive, who are maybe suicidal or hurting staff or pulling at lines, they're good candidates for medications. And of course, that's done with shared decision making with their family.
When you're reaching in your medication bag, what medicines are you reaching for?
Definitely Roserum. That's number one, because it sets your sleep-wake cycle. And people who we want to prevent delirium or are already delirious, we give them that unless you have fulminant liver failure. Then when we think about treating delirium, our three main categories are the antipsychotics, the benzodiazepines, and the mood stabilizers. And when we say mood stabilizers, in our hospital system, we're thinking about Depakote, because you can give that by IV or through oral route. In terms of antipsychotics, there's a black box warning, so you have to talk to all family members. Hey, this could increase the risk of cardiovascular event after a year or so. We talk about our Risperdal, Haldol, olanzapine, those types of medications. And then when it's indicated for people who have delirium because of drug reactions or drug withdrawal, we think about our benzodiazepines.
I guess big picture, would you say the mainstay of delirium treatment is more about treating the underlying cause and supporting the patient rather than just relying on medication itself?
Absolutely, because we know the delirious patient is responding to their internal environment, responding to the medical issues that's going on. So the first treatment is actually treat the underlying medical causes, understanding that it's going to take a while.
Dr. Bowe, I think this was extremely helpful. I think this case with Ms. Carter really is just a good reminder, kind of like you said earlier, delirium is common. It's not normal, but if we can catch it early, we can often reverse it. I think you highlighted some really important things in terms of treating the underlying cause. You talked about the non-pharmacological strategies that we have here at CAMC, and still know that medications can still have a role in certain instances. Really, you've walked us through three challenging cases. We may come across from first episodes of psychosis to substance use disorder to delirium in older patients. I know our listeners are going to take a lot away from this discussion and hopefully feel a little bit more comfortable when they come to these situations in their own practice. So thank you again for your time and insight, and thank you for just coming here and being with us today. Thank you guys for tuning in to another episode of Health Matters.
Thank you for inviting me.
Health Matters Today is a podcast recorded at Vandalia Health Charleston Area Medical Center Studios in Charleston, West Virginia. Hosted by Dr. Sheylan Spencer, directed by Dr. Amy Bruce, produced by Christopher Cobb and Jason Likens.